Very, very good evening for today, my beloved colleagues. Those who are here, welcome to all of you to today's session. Just to check my voice on the screen, may I request Dr. Iram, please? Is my voice is okay for you, Dr. Iram?
Yes, sir.
Okay, thank you. And
Okay,
the
very nice.
screen, also okay, visible?
Yes, sir.
Okay, thank you very much. Thank you very much. So we are going to session now. Get ready, and those who are late, let them join later. Uh, Already you are in time, and it is our gratitude to all of you. And this is my humble introduction as before. So our intended class today, we are going to start now. Before that, just to introduce our name of the institute. And today we are going to discuss the clinical approach to musculoskeletal disease. In general, it's a very big chapter to understand many things, but our intention is as a primary physician, preferably a family physician, how we can approach the patient presented with musculoskeletal symptoms clinically. There are many parts: clinical presentation, investigations, and the management as well. But the main part of the musculoskeletal system is the clinical presentation. And we have to be rather a master to explore the clinical presentation for the musculoskeletal systems. It's actually a diversified system and a multi-systemic disease it contains. So sometimes we may be wrong to identify the main problem. Patient may present with the cardiac problem, lung disease, kidney problem, but underlying disease is connective tissue disease. So overall, we will not go too much in detail today as an initial part of this type of discussion. We will remain as much as relevant, which will be much helpful for your AKT exam as well as OSCE exam as well. Moreover, it will be useful in your clinical practice also. So just have a look in the slide. You can understand that how a patient present with. In general, the patient may present with the bone pain and some joint issues. You see the many characteristics of the joint problem: periarticular pain, muscle pain, and patient may have extra-articular manifestation as well. And this is our challenge, and we will try our best to explain you in a very simplified manner how to identify the bone pain, joint pain, periarticular problems, that means the periarticular pain, muscle pain, and what are the relevant extraarticular manifestations. If you be attached with us today from beginning to end, I hope, we believe that you will be able to understand very easily to differentiate the different sources of the pain or other presentation of the musculoskeletal system. And like all other sessions with us, all the time you will have all the opportunity to ask any question or to discuss any issues in between the topic. No problem, you just raise your hand if it is in my course of talking, no problem. But we will give you sometime the opportunity to talk by yourself in between the class today. So now go on with next slide. So whenever we look at the patients, that is our impression and some examination finding in the musculoskeletal systems. Now you can understand that the musculoskeletal presentation is not confined solely in the musculoskeletal parts of the body. I mean the joints, ligaments, and others. Rather, it involves the skins, eyes, and many other organs as well. But these are very, very common findings in musculoskeletal diseases. Now, we like to discuss the bone pain a little bit now. And you can see that whenever patient present with bone pain, there are multiple possibilities listed in this screen now. And I hope all of you understood that the different, rather to say, different angles of understanding when a patient present with the bone pain. It is not only the bone tumor or bone infection, even the metabolic disease also can cause bone pain like hypercalcemia. Okay. And we need to able to differentiate all the underlying diseases if a patient presents with the bone pain. But now question is how we will understand the bone pain. Suppose the pain around the elbow, but it may not come from the elbow joint. The pain may come from the ends of the long bones. So these are some simple tips. By the history, we can get some idea. You see that bone pain usually that means onset usually spontaneous. Though there are some other diseases, joint related disease also could be spontaneous. Usually spontaneous onset and the traumatic onset, we differentiate the diseases into the medical disease and the surgical diseases. So anyway, usually the bone pain is a spontaneous onset, deeply seated, and pain is localized, not too much diffused, too much spreading to other parts, and the pain persisting most of the time of the day, though there may be some variations by activities. Okay, for example, if you consider the multiple myeloma, it is a disease of the bone marrow, but the presentation will be like bone pain, persistent pain, deep-seated pain. There is no diurnal variation almost. Okay. And just now a little bit about the joint pain. This is the main part of musculoskeletal system disease. Whenever we come across the joint pain, we can think the arthritis. But remember, joint pain solely is not the feature of arthritis. You know, the features of inflammation are multiple, including the swelling, dolor, calor, rubor, tumor, functionalisa. You know the very, very basic characteristics of inflammation. So almost all the features will be there in the joint. Then we can say this is arthritis. If only pain, you know that we say the arthralgia. But the main point here, we like to discuss this to understand the different diseases of the joint. We need to know about what are the inflammatory features, what are the mechanical features. In general, the mechanical joint pains usually more common than the inflammatory joint pain. But as a disease, inflammatory diseases are of utmost importance. The prognosis, the treatment is very not like the mechanical pain, outcome not good as mechanical pain. So there are some distinguishing features you can see there. If anything you need to know, you can just ask me. We will not go in detail to describe all the simple things because our time is limited today to finish all other parts of the discussion. So these are the features to differentiate this thing. And now some other points of the inflammatory pain is insidious onset, improvement with gentle movement, and there is no improvement with rest. So these actually differentiate from the mechanical pain. And try to remember the things, improvement with the gentle movement. If you ask directly that after walk, what is the change of the pain, it will not be a good question to the patient. We need to ask this, does the pain improves, that means relieved after gentle movement, not very vigorous movement. And like any other diseases, the vigorous movement will increase the pain, no doubt. So these are characteristic features of the inflammatory pain. Another feature is very important feature for the joint disease, especially the inflammatory joint disease of synovitis. This is the joint stiffness. And this is the characteristics of the joint stiffness. What does it mean? I like to highlight here. The stiffness is either a loss of range of movement plus minus pain. That means pain may not be there, just restricted movement of the joint with or without pain, and pain will be on movement. On movement, there may be pain, may not be pain. Especially pain will be there following unaccustomed exercise. So, the joint stiffness we need to clarify because patient will be confused. We need to explain to the patient what actually patient means by the stiffness. If anyone of OSCE candidate today here, just try to remember the stiffness in the layman term will be jamming. Jam, simple word in English, jamming. Okay, stiffness may, will be a medical word, jamming. Okay. And morning stiffness especially is very characteristics of the synovitis like rheumatoid arthritis. And it is shown in above panel that the morning stiffness is more than 1 minute. It is more likely inflammatory. But like osteoarthritis, we tell osteoarthritis is non-inflammatory disease. In the osteoarthritis also there is jamming. In their word it is said as gelling of the joint. So this is not the stiffness by definition, and gelling usually will be less than 3 minutes. So during the evaluation of the patient, the duration of the stiffness also important, as well as the diurnal variation means the morning stiffness is very important. Okay, thank you, Dr. Nasir. Now is voice okay, Dr. Nasir? I'm sorry, little if any distortion there.
Yes.
It's clear now. Thank you. Thank you very much. A more weapon with us, as we discussed that it's to be differentiated, the inflammatory disease or non-inflammatory disease. If we are confused, definitely we will need to take the help of investigations. Anyway, as a clinician, our first job is to differentiate, and the investigation will not be too much. Today, at the later part of today's discussion, we will show you the investigation approach also a little. But look at that. We have shown to you only to differentiate the inflammatory presentations. Very simple test, complete blood count, ESR, CRP, will be able to differentiate these are the symptoms is of inflammatory origin or not. That means if you think it is a gout in the knee joint, you will get the raised ESR, raised CRP. But if it is simple osteoarthritis, usually ESR and CRP will be normal, including CBC normal. Normal means there are some features, possibly you know, the acute phase reactions. There are some features in the CBC report. So all will be almost normal in osteoarthritis. But if it is a gout, it is a part of the rheumatoid arthritis or other diseases, you will get the markers of the inflammations are high. So it's very easy. And the later part of the specific test, I hope to discuss it later today, not up to this, just to show you the panel, how to proceed with the investigation. Our initial investigation will be this thing, only to identify this is inflammatory or not. Now come to the joint area. If any patient present with the articular or periarticular problem, definitely we need to know, we should be able to identify the pain is articular or periarticular. We will summarize a little later also in the coming after a few slides, but you just look at the periarticular problem. There will be point tenderness over the involved structures and the pain exacerbated by the movements. But you already know that pain will be exacerbated by the movements even in the articular disease also. But by the gentle movement, pain will be relieved. So there is some critical matter to be understood. And in general, in the joint disease, pain at the end of the range of motion is important. Remember, in the periarticular problem, pain exacerbated by movements, they throw out the range of movement. That means you are doing flexion, extension, and others. But in the joint problem, at the end of the range of movement, pain will be more. Usually at the end of the extreme point of the range of movement. That is at the extreme of the flexion, extreme of the extension, like that. Anyway, and if it is articular problem, again, we need to differentiate. This is inflammatory or mechanical. Already we discussed. And if it is a periarticular problem, which structures is causing the pain, it is important. This is the bursa, tendon, and others. Then the exploration will be too much. Anyway, so with these few words, as a family physician or general physician, as we are not a specialist, we must know about the red flags in the joint disease or musculoskeletal disease. These are the list. So I will not go through now. You already looking, and try to remember. If needed, whenever you need, you can make the snapshot also. Now, if a patient presented with the multiple joints, again, the theme is as before also. What we discussed in the pain in the single joint, mainly the same. It is articular pain, periarticular problem. Usually multiple joint pains will be the joint disease. That means there will be less confusion about whether there is periarticular problem or not. Periarticular problem will create a confusion if patient presented with a single joint. But in the multiple joint problem, more likely this is joint problem. But our challenge again, it is inflammatory or not. So already you understood how to differentiate. We'll discuss including the blood test also as well. Autoimmune profile, it is for the etiology clue. But initial, the primary investigation will be the complete blood count, ESR and CRP. Okay. So these are the list. Common arthropathy means the joint related diseases. We must know about each and every disease. So this is not our today's intention to discuss each and every disease. We will be very superficial to identify the different types of the disease. Okay. And again, the red flags already you have seen before, and these are the same thing here. Red flag, we must know about red flag, and whenever red flag, we will be very cautious, and most of the time we need to refer the patient to specialist. In the patient having the joint swelling, you know that the osteoarthritis hand. Can anybody say, already some of you possibly attended our discussion in our recall classes and many sessions. In the hand, distal interphalangeal joint, patient may have swelling there. So common two DDs will be there. One is the gout, preferably the chronic gout, another is osteoarthritis. Who can say how to differentiate the gout and osteoarthritis? Please, anyone. Sometime I like to hear from you. Don't think I will continue the talk. Please. Anyone, please. In the hand joint, distal interphalangeal joint.
In gout, there will be a warm and swelling, warmness, redness, like acute inflammation. But in osteoarthritis, there will be her burden nodes, like hard nodes without any warmth and swelling, warmth and tenderness, or
Yeah, thank you, doctor. You said many things. You are very right, very right. But only simple thing to differentiate. Suppose there is some exception in osteoarthritis. It is called erosive osteoarthritis. I will not detail too much. And erosive osteoarthritis is one of the variation of the inflammatory arthritis. So in that case, you will get the warmth and other also, doctor. Okay. So very simple thing is that if the bony swellings are hard, what you said, Habardens node and the Bouchard's nodes, this is characteristic for the osteoarthritis. But the chronic gout, these are the top 5, these are soft. though you can say many differentiating other points. The tophi are yellowish or white like that. Many other things. Just simple clue. Simple clue. Hard nodules is Bouchard nodes are characteristic for the osteoarthritis. So in the joint swelling, definitely is a single joint swelling. More likely this is infective. But if joint swelling of the multiple disease, it will be inflammatory in nature. These are the things. So some differentiating points and relevant information shown in the slide now. And now come to very, very important picture in the patient presented with the multiple joint inflammation, rather to say inflammation, or even we can differentiate by traditionally non-inflammatory disease means osteoarthritis. So uh, I don't know where I have talked about this few days before with you. Anyone attended? Can you tell me here? There are 4 diseases. Is there a similarities having with any other picture from the BCD? The presentation of the joint similarities in BCD. No one is 100% same, but there might be some similarities. Can anybody identify?
Yes, 1 and 4
1
have
and 4.
some
Oh,
some
let's see. 1 and 4. Why you are telling that these are similar?
like involvement of hands,
Hand
bilateral
joint, yes, hand joints, knee joints,
knee
foot
joints.
joints, right?
Yes.
Foot joint. So can I ask other colleague? Anyone please open Dr. Asha or Dr. Iram, anyone? Just to be with us in the discussion. In the 1 and 4, what dissimilarities you are getting? Please, quickly, then you will enjoy the class nicely. Dr. Iram, what dissimilarities?
Uh, Fourth is big toe involvement to the gout and a smaller joint involvement in the first is rheumatoid arthritis.
Sorry, doctor, not clear somehow your voice. In the hand joints, you see characteristically in the hand joints, the distal interphalangeal joints spared, spared. But
Multiple joint involved.
multiple is true, both A and D. But the pattern, in the pattern of involvement, in the D, distal interphalangeal joints are involved, proximal interphalangeal joints are involved, and these are not symmetrical. Not symmetrical means if you compare the ring finger here, you see in the ring finger, the proximal interphalangeal joint is involved. But in the left hand, the proximal interphalangeal joint is not involved. This is the asymmetry. And the word meaning, if bilateral is true, in the A, there's a bilateral joint involvement. Here, bilateral joint involvement in the both hands. But in this A, they are symmetrical, but in the D, these are not symmetrical. Clear, doctor? I think Dr. Iram is busy. Huh? If anybody talks
Yes,
to me, please keep connected with me. It will be easy. So in this way, we will not discuss too much here. If you see that the involvement of the spine is characteristic for C, spine, as well as sacroiliac joint. So what is the C diagnosis here? What is
ankylosing
ankylosing
spondylitis.
spondylitis? So in the B also, there is a spinal involvement. True or false? Who can say?
No involvement.
No involvement of the spine. Doctor, please, I remember your voice. I'm sorry, I cannot utter your name because your name is not shown. May I know your good name? I will be happy to address you well.
Yeah, Dr. Mohsen, Dr. Rahim
Mohsen, yeah, Dr. Mohsen.
Mohsen.
Yeah, I remember this name. Sorry, as you didn't write. So, Dr. Mohsen, uh, you see, this is a sacroiliac joint.
Yeah.
Okay. If I
Yeah.
ask you, is it a spinal joint?
No, it's
Possibly you are
peg.
telling no. Possibly you are
No,
telling no. Okay. But today, some of other colleague will say, yes, this is a spinal joint. Who want to say? Anyone, please, quickly? The sacroiliac joint.
I would say spinal if
Yes,
sacroiliac joint
yes,
is
yes. Thank
involved.
you. Thank you very
Thank you.
much. So, Dr. Mohsin, for your kind correction, This sacroiliac joint is actually a modified spinal joint. You see, in the middle, there is no joint. So
Okay.
it is an arrangement of the bone during the development. The spinal joint actually pushed aside, left side and right side. For this reason, whenever we designate a disease spondyloarthropathy, remember the word spondyloarthropathy, it means the involvement of sacroiliac joint. Clear,
Hmm.
doctor? All of you,
Yeah.
please remember. Without the sacroiliac joint involvement, we don't say spondyloarthropathy. But here, the very prototype typical spondyloarthropathy is the primary spondyloarthritis, that is so-called ankylosing spondylitis. Why I am telling so-called? Ankylosing word is an old word. Ankylos means fixed. Suppose decades before, when patient presented and diagnosed, in this time, patient's joints are already fused. For that, the term was ankylosed. That means ankylosing spondylitis. But nowadays, before fusion, before ankylosis, we are able to diagnose ankylosing spondylitis. That means so-called ankylosing spondylitis. So our current terminology is spondyloarthropathy. Now the spondyloarthropathy is the primary and the secondary. Primary means without any recognized etiology is the primary. That will be like C, bilateral sacroiliac joint. But here in the B, the secondary spondyloarthropathy, for example, psoriatic arthritis involving the presentation with the oligoarthritis. So one of the secondary spondyloarthropathy is the psoriasis, and usually there will be unilateral involvement. Even in infective process also there, we expect that there will be unilateral involvement. Moreover, if there is bilateral involvement, there will not be symmetricity. I believe that you already understood the meaning of symmetricity. Suppose in the C, the primary spondyloarthropathy, the involvement is same, 2 and 2, for example. But here, there will be some dissimilarities. It may be bigger, it may be smaller also. But in general, if any unilateral sacroiliac joint involvement, we term it the secondary spondyloarthropathy or secondary spondyloarthritis. And whenever you come across about the spondyloarthropathies, it will take long discussion. In general, at the bottom line thing is that spondyloarthropathy divided into two broad heading. One is the axial spondyloarthropathy, another is the spondyloarthropathy associated with the peripheral joints. It has some importance in the management as well. So I believe all of you understood, and you will go through detail about this, and it will be very fantastic and useful picture. In any other time you don't understand, please you can rediscuss also with us. So I am switching to the next slide now. By looking at the hand also, you can identify the different diseases. You see, like the palmist, right, in the street side, the palmist, and more common in South Asian countries also. So as a doctor, looking at the hand and the pattern of the joint involvement, you can identify. You see, already we discussed the rheumatoid arthritis in the, you see, distal interphalangeal joints is paired. So whenever distal interphalangeal joints are involved, so the differential diagnoses are there like that. So in this way, if you go through this, just to finish this thing by telling one thing, CMC, first carpometacarpal joint, is very significant for the diagnosis of osteoarthritis. And this is the wrist pain means carpal tunnel syndrome. You already understood. Carpal tunnel syndrome, that means inflame the flexor retinaculum. And just to add, you already we discussed periarticular disease. Flexor retinaculum, it is outside the joint. So it is only flexural area, and we told already the point tenderness on the involved part. So you will get the tenderness in the flexor part of the wrist, but not in the extensor part. But if it is the wrist joint involvement, doctor, remember, wrist joint, for example, in the rheumatoid arthritis, you will get throughout the circle of the joint surface, you will get the tenderness. Dr. Mohsin, clear now?
Yes, doctor.
If it's clear to you, I hope clear to other participants. As you are interested for that mentioning you, other doctor, please don't mind. Feel free to be part of our discussion. So now, as a regional pain, as a common, I'm not telling like today as a specialist, but as a family physician, and definitely in the AKT or the OSCE again will be useful. Just if a patient presented with a thumb pain, there may be joint related disease, there may be periarticular disease. From the big list, the very popular, and you must know, are the three are here: osteoarthritis, trigger finger, and the D-curve veins. So I don't think that it needs further elaboration. So there are see big list are there, but just three things. They already mentioned the three things also here. More discussion. Easy to understand. Come to the wrist presentation: rheumatoid arthritis, carpal tunnel syndrome. But sometime again, the decorvens tenosynovitis also, patient may present to you by telling doctor, I am having problem in my wrist. Okay, remember it. I'm just showing a little few seconds video, and everybody will feel free to tell me the diagnosis, please. This was my patient, recorded by myself also. Please have a look. What is this, please? What is the diagnosis? Decorvein. Any other colleague like to hear something else? Please, anyone? It's very simple. If you didn't see before, maybe confused. But anybody have seen it before, it's very easy. Dr. Mohsin?
Sir, may it be a finger lagging behind, like
I'm showing you again. Look at.
yes, a target
Yes.
finger, trigger finger, I think.
Yes, Dr. Mohsin. Dr. Mohsin, why not you change your name here in the Zoom if you don't feel any problem? Otherwise,
Inshallah.
I don't let me put myself in problem by uttering your wrong name. So please correct your name. So this is the trigger finger. This is the trigger finger. Is a joint disease? No, it is not joint disease. So, but common in your general practice, and it's a case of your OSCE also as well, in the AKT also as well. Okay. Anyway, this is my opportunity to present this trigger finger. Is I remember now is my Middle East country job. That was the picture my assistant was put this, and she was helping me. Anyway, I remember. So now come to the elbow pain. Tennis elbow, golfer's elbow, and as a multisystemic disease or multi joint disease, rheumatoid arthritis in the elbow. But in your exam, more commonly it will be tennis elbow and the golfer's elbow. Okay. You see, many things happen here, but I'm just rather shouting to you, rather to say, I'm very loud to say these common diseases. If patient having the shoulder pain, frozen shoulder, rotator cuff tear, and the impingement. Maybe in the last AKT also, those who attended, I can remember. No, we sit with the recall session, AKT, right? Few weeks before. That was impingement more likely, I can remember. So don't think that all shoulder pain will be frozen shoulder. There will be impingement as well. And if patient presented with the neck pain, there are multiple differentials. Even the muscle spasm also there. But as a disease, cervical spondylosis, we should not forget. And the neck sprain and the muscle spasm. Neck sprain means ligamental issues as well as muscle, but simple, only the muscle problem also. Possibly some of you, I believe that might have in your life like torticollis. Possibly have you heard the word torticollis?
Yeah. Persistent posture, one-sided
Yes,
posture.
yes, like the bird, like a bird, right?
Yeah.
Have you seen the bird? I don't know
Yes.
the name of this. There is a local name. I don't like to utter in this international session today. So this is like a torticollis. It is a muscle spasm. Okay, it is not the joint disease. Very simple to identify. Very simple to identify. Anyway, now something about the low back pain. Multiple problem. Mechanical pain is the commonest cause of the low back pain. Mechanical pain. But as a physician or the doctor, we must know about the spondyloarthropathy. Already we discussed before. And the degenerative disease is lumbar spondylosis. So spondylitis and the spondylosis, there are two different things. You will go through by yourself. You will go through by yourself. There are many other diseases also in the OSCE. There could be prolapse in the vertebral disc as well. Okay, something. But the priority we mentioned here, don't think that this is a complete list. Whenever needed, I will utter additional diagnosis also. Okay, spinal stenosis. So in nutshell, in the low back pain, 4 or 5 diseases are there. You need to know almost all of about this, including the spinal stenosis also. Now a detailed approach in algorithmic approach for the low back pain. There are different types of the disease involving the back of a person. Our main agenda here is inflammatory and the non-inflammatory. Inflammatory traditionally mean is the rheumatologic disease. In the box you can see. Whenever a malignant disease there, by definition, there will be some inflammation, no doubt. But in the medical science, there is a tradition. It is not exactly science. So, the malignant disease, we categorize the malignant disease as malignant disease. You see, there is an infection also. It's very commonest cause of inflammation is the infection in another system we are reading. But here, we have given the name of infection under the destruction. So this is the way of learning. Okay, if we think that the very basic thing, all the basic things are not fit with all the systems. So there will be mechanical pain, destructive problem, inflammatory disease, and other issues. Suppose prolapse intervertebral disc. So patient have the neuropathic pain. So all the diseases are important. We need to be able to identify. And already we have told you the differentiating point between inflammatory disease and non-inflammatory disease. In other diseases, there will be other clinical symptoms and other clinical signs. If not possible, definitely we will go for the investigation, especially the imaging. That's all. And the main thing as a family physician, we need to able to identify any emergency things happened or not. Okay, especially cord compression or the root compression, and it needs emergency decompression, rather to say, to save the nervous system. So if needed, we will immediately refer the patient to the neurosurgeons or spinal surgeons. You know the name of the disease is the chorda equina syndrome. So as a general physician, you will be asked in the AKT, especially what will be your management action plan. If you say this is the decompression, though this is the correct answer, but as a family physician, as a general physician, it will not be the correct answer. General physicians are not privileged to treat the surgery or surgical treatment of the nerve root compression. Okay, so what will be the answer? Answer is immediate referral to the spinal surgeon or neurosurgeon, rather to say. In between, though, there are some other medication like the steroids, a little higher doses. This is other thing. So main agenda is the referral, and the specialist will do their thing. So as a family physician, what will be your answer? You must know. So we will be coming to a session in future by the mercy of Almighty in the few days later for the preparation of AKT. Anyway, so these are the red flags list are there, and in the textbook also red flags given as such. You just compare and contrast from there. Almost things are same. Things are same. So red flag feature may be in the history, red flag features may be in the examination findings. Even red flag feature may be in the investigation also. But traditionally, we are today also we are discussing the clinical features more and more. Even the back pain with the fever will be the red flag. Red flag means patient needs further evaluation and patient may need evaluation by the specialist. Okay. But remember, the red flag does not always meaning underlying pathology is very serious. Suppose if it is not the malignant disease, patient may have more pain for other nerve root, a little mild involvement or persistent pain. So you can handle also few cases. If needed, get the support from the physiatrist. Okay, you can keep the patient few days, few weeks. Later you can refer. So it is not that 100% red flags will be having underlying serious disease, but most of the time these are the serious disease. For that we have to be very cautious. Regarding the back pain, this is the diagnosis for ankylosing spondylitis. Who can say why we are telling? In the investigation, I am not telling the clinical features. Please, anyone?
So bilateral sacroiliac joints prominent white
Yes, yes.
white.
Now, Dr. Mohsen, now it is very clear to you as you are participating in the discussion. So, sacroiliac joint is a spinal joint, right? Because this is spondyloarthropathic. Remember it. And there may be other features we are not going to discuss about. If you clinically you are suspecting spondyloarthropathy, you may not have features in the X-ray. X-ray is a poor quality imaging. In that case, our next approach will be sacroiliac joint MRI. It will be more sensitive, more specific. So this is the appearance in the MRI, sacroiliac joint. And why I am telling, you will understand. This is the diagnostic criteria by ASAS traditionally. The left column is by the X-ray. Left column is by the X-ray, the or by MRI. This is the priority. Sacroiliac is on imaging plus more or single SPA features. Actually, SPA feature is in the down, whole list are there. But when to evaluate this? If patient having more than 3 months low back pain, usually low back pain, less than 45 years of age, usually male patient, remember, usually male patient. So a male patient presented with the low back pain more than 3 months and the age usually less than 45, we need to suspect and we need to exclude spondyloarthritis. Spondyloarthritis in axial spondyloarthritis. If we don't get imaging feature, then we can consider the right side column. And here the headline will be HLA-B27 plus two other features from below. This is another way. So without imaging also this is possible. And these are the legends you see A, B, C, D, their explanation. We will not go through there. You can see in the book also. Description. Now this one, already arrowheads are there. It is also a low back pain patient. What is your diagnosis? Quickly, please. Quickly.
Ankylosing spondylitis.
Ankylosing. Yes, now this is ankylosing. Very right. Ankylosing because the vertebral joints are fused. So this is very advanced disease. This is what our traditional. It is a primary disease or secondary disease? Dr. Shazia, you are telling maybe. Primary disease or secondary disease?
Primary.
Primary because bilateral, symmetrical. What is the name of this area? Is a bone or something else?
So vertebral.
This is a part of intervertebral disc. Annulus fibrosus. So what is
Yes,
the
sir.
modified here in the disease process? Nobody can say, please. If you stop me, then there will be more time to finish. Syndesmophyte. Okay, syndesmophyte. In the osteoarthritis, there will be osteophyte. Anyway, today is not the radiology session, so I am jumping. Now come to the hip pain, hip presentation. Commonly, hip osteoarthritis, again part of the spondyloarthropathy with the peripheral joint involvement. There may be other problem also. Periarticular disease also will be there. It is called the trochanteric bursitis. Trochanteric bursitis is also one important differential of the pain around the hip. Okay. Again, the hip fracture or orthopedics are there. Knee pain, osteoarthritis, osteoarthritis, osteoarthritis. I uttered 3 times so that you shouldn't forget, especially for the general physicians. And the Becker cysts are not much common though. The Becker cyst in the back. You see about this is the protrusion of the synovial membrane. Becker cyst. So these are 2 important diseases in the knee presentation. Though there is a chance that knee will be involved in the septic arthritis, gout, especially the pseudo gout rather to say, or even the rheumatoid arthritis less commonly, and the ankylosing spondylitis with peripheral joint involvement also. But number 1 will be osteoarthritis. There may be some orthopedics issue by the trauma, injuries of the intra-articular structures. Okay. And the ankle pain, arthritis and the fractures. Which fracture common here? Doctor, what is the name of this fracture?
Malleolar.
Malleolar fracture, yes. Malleolar fracture. Now come to the heel pain. Many. Which you have seen in the heel pain, doctor? What you have seen in the heel pain patient in your practice? Nobody have seen at all. Heel
Achilles
pain.
tendinopathy. Achilles.
Achilles tendonitis. But I like to say I have seen calcaneal spar.
Plantar
Plantar fasciitis or calcaneal spar. Anyway, you are fortunate. You have seen Achilles tendonitis. Now, thing is that, especially in this area, if patient having the plantar fasciitis or even calcaneal spar or Achilles tendonitis, if the lesions are bilateral, plus patient having the fever, anorexia, what could be underlying disease? Please respond quickly, anyone. It is only the calcaneal spar or something else. Can anybody add? So as I said, there is a fever, loss of appetite, there are some general features. So whenever the general features are associated, it is a systemic disease. It is a part of spondyloarthropathy. So these are the enthesopathies. So if it is a bilateral, we need to exclude spondyloarthropathy. It means we need to ask the patient, do you have low back pain? That means I am meaning sacroiliitis. Or did you have low back pain before? Very important message, doctor, remember. You have seen already heel spar, calcaneal spar. If you don't find a spar but patient having typical heel pain, then it could be plantar fasciitis. Okay, let's see now. About the foot in the grade 2, gout. And the bunion, hallux vulgaris, possibly this was a question in the AKT, right? Some of you can say in the last AKT exam. There's a picture, maybe clinical picture of bunion. It was not gout. So don't be confused. Gout is very intensely inflammatory lesions. So minimum bunion and the gout. Don't forget. There are some other issues also. So up to this, if any query in your hand, please open the mic and ask, doctor. Otherwise, we'll go to the next topics.
Sir,
Shazia, please welcome.
sir, if there is no spur on X-ray, then it will be plantar fasciitis or it can be plantar fasciitis.
In the X-ray, very minor features and usually no features found in the plantar fasciitis, because plantar fasciitis is not a calcified material truly. Okay, but calcaneal spur, there is a degeneration, and calcified materials or tissues are more congested. Actually, this is a bony outgrowth, but
Yes, sir.
plantar fasciitis is not bony outgrowth. So in the X-ray, it is unlikely to be seen anything there. Okay, clinical it is possible to check plantar fasciitis and other. There's some clinical maneuver. If you go through the book, you can identify how to identify the plantar fasciitis. There is some clinical examination also there. Okay, and
Yes,
for
and
the
sir,
please,
one
please.
sir, one symptom patient always says early morning pain when he keeps foot on the ground.
Yes,
In the case of plantar fasciitis,
yes.
and he will feel pain in the case of spur almost most of the day.
The presentation almost same in the calcaneal spur and plantar fasciitis. Whenever patient put the foot on the ground in the morning time, there is a pain. After a while, patient walks, pain is gone.
In
Okay,
plantar fasciitis.
both, both plantar fasciitis
Right,
as well as calcaneal spur, both.
right, sir.
Okay,
Thanks.
yes. But very interesting in the answer of AKT, though possibly I will not show it. I will discuss it later. The management plan of these, many of you will differ because this is AKT. It is not a specialist. It is not rheumatology of the rheumatologist. So management plan will be a little different, and we discuss anyway for the plantar fasciitis. The topic is very simple, but technique is different. We hope we will discuss it in later also. So thanking you, Dr. Shazia. We are now coming to the periarticular problems. How to identify. First of all, periarticular means already we have discussed something tendonitis, epicondylitis, yeah, fasciitis, tenosynovitis. And periarticular infection usually less common. Okay, because why less common? Periarticular tissues are avascular. So the movement of the organism are less in the periarticular tissues. Now, how to identify the articular and periarticular? This is the list. Okay, so I hope if you make the snapshot, you will go through by yourself. The basic thing is the movement types. We need to know passive movement, active movement, and the restricted or resisted movement. Okay, who can explain these three movements? Passive means you are moving the part of the patient, passive movement. Active, patient is moving, active movement. Resisted, patient is moving but you are obstructing. This is the resisted movement. So by these three maneuvers, you can identify which one is articular disease or periarticular disease. I hope this slide will be useful for you. And these are some non-articular. Usually, you see, the outside the joints mainly, many, and these are not uncommon, doctor. A GP rather to rely upon these and no need to refer all the cases. So all of you must know, and your AKT topics full of this diagnosis. Almost maximum there, including the trochanteric bursitis. You see, I told you around the hip, trochanteric bursitis. Okay, so there are joint disease as well as the periarticular problem mostly. And one important thing we would be confused is the T's disease or T's syndrome in the chest. If it happened in the left side, sometimes patient as well as doctor confuses with the myocardial infarction. So how dangerous it could be. T's disease. If you understand what is T's disease or T's syndrome, you can assure the patient, don't worry. Don't worry. T's disease or T's syndrome. So these are varied musculoskeletal conditions, more common in the practice. So if we summarize in another way, the presentation of the patient, we can say in the musculoskeletal disease evaluation, we can make a simple categorization that Does patient present with arthritis predominant conditions? For example, you know, the rheumatoid arthritis, the psoriatic arthritis. You can remember that these are arthritis predominant, not arthralgia, arthritis. But like the disease of SLE, systemic sclerosis, patient would have joint problem, joint symptom, but in the connective tissue predominant disease, other than the joint problems are more. There may be skin problem, there may be the connective tissue problem, other tissues, collagen tissues and others, including extra-articular manifestations. So there are two headlines. Third headline will be periarticular diseases, just around the joints. Then it will be very easy for us to identify the diagnosis. So if we summarize these musculoskeletal complaints, we can go through by this algorithm. Definitely we are taking the history and we have done physical examination. So that almost the repetition, it is articular, periarticular or other, and it is acute disease, chronic disease. Is there any features of inflammation, and how many or which joints are involved? Already you understood. How many and which joints? Pattern of the joint involvement. By this question and getting the answer, we are summarizing here that this is articular. Okay, this is articular. Now, if the complaint is more than 6 weeks, this is chronic disease. If it is acute, less than 6 weeks. Okay, articular. Now, if it is not articular, the main bulk of the disease in the general practice is non-articular. So, it could be fracture, trauma, fibromyalgia, polymyalgia rheumatica, bursitis or others, or the tendonitis. Okay. Now, if it is acute and chronic, then the algorithm will go run to the rheumatologic other diseases. Now consider acute arthritis means the left box, chronic arthritis means the right box. From the right box, you see in the chronic how many joints we are dividing into the oligoarthritis, monoarthritis, polyarthritis, like that. By this algorithm, finally we'll be able to osteoarthritis, rheumatoid arthritis and others. But in the later part, you see, by this calculation, if it becomes very difficult to say this is rheumatoid arthritis, this is psoriatic arthritis and others, if you cannot, then think of systemic lupus erythematosus, scleroderma or polymyositis. What does it mean? I told you before, the connective tissue predominant disease also will have joint problem, joint swelling. Okay, so this is the algorithm, and you can, and always by myself personally, I don't like to agree with the algorithm remembering or memorization, but we need to get understanding. So don't be busy only simply memorizing the algorithm. My suggestion is to understand the algorithm. Okay, it will be easier for you. And this is the way of learning, by learning questions like AKT or other clinical exams. Whenever you go through the question bundles, the algorithm will be easier for you. But simply memorization of the algorithm, I don't like to advocate. I discourage it rather. It will be automatically will come into your mind if you go through the scenarios of the patient. Okay. So after the joint problem or periarticular issues in your AKT, I understand some questions will come from the deformity. Okay, so deformity may be temporary or permanent, and deformity usually dealt by the orthopedicians. Okay, there may be some congenital problem or acquired problem as well by the fractures. Myalgia, a very critical presentation sometime if the patient having the fibromyalgia is very common in the exam. Okay, so it's a muscle pain, fibromyalgia, chronic fatigue syndrome. Okay, whenever you go through the fibromyalgia and chronic fatigue syndrome, try to identify this. There are some differential diagnoses. These are the differential diagnoses of the generalized myalgia. And one thing is not mentioned here, it is hypothyroidism, remember. Hypothyroidism also can cause generalized myalgia. Another one is polymyalgia rheumatica. But for the GP, we highlighted here is the fibromyalgia. the chronic fatigue syndrome. Okay. A little more about the fibromyalgia, especially the tender points. Try to remember, try to remember. And the basic thing is the tender point should be in the both left and right side of the body and below and above the waist. Above the waist, below and above, but there will be both side of there. That means a bilateral tender point. This is the basic concept, and these are the list of the tender point. There is a 9 tender points area they mentioned here. Okay, pain 11 out of tender sites, but the anatomical location is the 9. There is a bilateral for that list is 9, but point will be 18. The fibromyalgia. And something about the extra-articular manifestations. Lung, heart, neurology, skin, blood vessels, as well as the eyes. These are common sites for the extra-articular manifestations of the musculoskeletal disease. This is the iritis, margin is irregular, iritis. So you may think that this is an ophthalmologic. No. If you find there is an features of the ankylosing spondylitis, primary or secondary could be, there may be iritis. So this is primarily a rheumatologic disease. Though we take the suggestion from the ophthalmologist to save the eyes. So this is iritis. Another one, scleritis, red sclera, could be part of rheumatologic. Who can say this appearance? Who can say? Anyone?
Derma.
No, you say the findings, your observation.
Shining and shining tough
Shining
skin.
and the tightening of the skin. Is there any joint problem also?
Joint deformity.
Could be there, could be there, could be there. So we told that in the connective tissue predominant disease also there could be joint issues, but not that much florid like rheumatoid arthritis or psoriatic arthritis. Okay, the destruction is less likely in such diseases. So next one, part of the systemic sclerosis, CREST syndrome. Possibly we discussed in your AKT recall, CREST syndrome features. So there are also extra articular manifestations are there. Predominantly rather to say esophagus, intestine and others also. Skin as well. What you are looking there? Quickly please, so that we can proceed. Dr. Sharma.
Corrugation of the mouth cavity and peaked nose.
Peak
SLE.
nose. And
red
the red spots.
rash. Mallar rash.
If you suspect the diagnosis, what could be the red spots are there? Telangiectasia. Okay, tight, shiny skin, suggestive of scleroderma. So these are the other features. You see joints, skin, vasculitis all together. There may be Raynaud's problem, Raynaud's phenomena. Microstomia, many things are there. So this is one. So scleroderma, we can divide into localized and the systemic. Okay, including the morphia, limited and diffuse. So today is not actually a scleroderma class, just showing you. This is the localized morphia. So I like to share the message that if patient having the skin problem, it is not only primary skin problem, it could be part of the spectrum of generalized disease of musculoskeletal system. So this is the morphia. This is anco-disabor in the forehead. Again, skin thickening like this. In the eye, heliotrope rash, suggestive of dermatomyositis. Heliotrope rash again, heliotrope rash. Who can say the diagnosis here by looking at the face?
SLE.
SLE. Characteristic feature is
Mallar rash.
photosensitivity. Okay, Mallar rash, photosensitivity, sparing the nasolabial fold. So this is SLE, part of the SLE. So these are some hints about the connective tissue disease. Any question from you, please? Few seconds for you before jumping to other.
In case we suspect inflammatory disease, As a primary care physician, after checking the CRP and ESR, what are the investigations that we should do, like ANA and all these
Other investigations, for example, doctor, can you mention?
other investigations, ANA,
ANA,
antibodies?
DNA. Yes, I will come to that point. Please, few minutes later, I will give you your answer
Thank you.
because we kept it
Sir,
pending. Any
can
other
you please,
question?
yes, sir. Can you please uh, help in confusing words Reiter syndrome and reactive arthritis? How can we differentiate between those?
Raters and reactive. Dr.
Is it
Raters is actually a diagnostic triad. Okay, raters. There are three features should be there. But it is said nowadays the usually three features are not common in a single patient in the single time. For this reason, the practical term would be reactive arthritis. Okay, Dr. Mohsen. So reactive means reaction to other disease. Very simple mechanism, post-infection situation. Where is the infection? Previous history of infection, 2-3 weeks before. If you can remember post-streptococcal glomerulonephritis, okay? I mentioned this for as a common disease. So infection happened 2-3 weeks before. Now patient presented with joint disease. It is reactive arthritis. Usually these are oligoarthritis involving the big joints, not rheumatoid like. Okay?
okay?
And two infection common site is the genital tract and the GI tract. We tell it Yara and Sarah. Have you heard it, doctor? Yara and Sarah?
No, sir. Yeah.
Enteritis associated reactive arthritis. Sarah is STD associated reactive arthritis. Okay?
Can you repeat, sir, please?
Can you repeat, sir, please?
Don't mind if any doctor today names Sarah or Yara, please. It is Sarah, SARA. STD associated reactive arthritis. Another one is the GIT, Yara, enteritis associated reactive arthritis, EARA, enteritis associated. And in the enteritis, there are some common organism though, okay? Please, you go through your book detail. Any other time you can discuss in the WhatsApp group, no problem.
Thank you, sir.
But let me finish today's talk, okay? These are fantastic and nice questions also. Now come to the investigation. Dr. Atif, yeah, thank you, Professor Lvi. You raised the issue and very happy to know that you are eager to know. And Dr. Atif could be connected with me if possible, so that interaction will be there. Whenever we talk about the investigations, the list of the investigation here, definitely the blood test. Okay, first. But we need to go for the imaging and we need to go even for the joint fluid aspiration and further study. Sometime biopsy needed and sometime electromyography also needed if you consider the dermatomyositis or polymyositis. Simply it is a muscle disease, you know the example of muscle disease, Duchenne muscular dystrophy, Baker's muscular dystrophy. Okay, so if we suspect purely muscular disease, for the confirmation of the diagnosis we may need electromyogram. But the commonest and the first investigation, mainly blood test, complete blood count, CBC, and the ESR, mainly to differentiate from the inflammatory joint disease. Then we will go for that. Come to now. If you follow this one, this though arbitrarily actually developed by ourselves, for my better understanding, I have thought in this way. I believe it will be useful for you and be with me in this discussion, please. Whenever we are thinking it is inflammatory disease or not, suppose connective tissue disease or the joint predominant disease, initial investigation will be CBC, ESR, CRP. But remember, clinically, if you are in the side of the SLE, you are having some diagnostic feature of SLE. Doctor who raised the issue, can you be connected with me? I will feel privileged. Yes.
Yes.
Be with me, doctor.
Okay.
Suppose if you are thinking that patient have SLE, you know the diagnostic feature of SLE, doctor? Oral ulcer, malar rash, photosensitivity, so on. So you are suspecting a clinical diagnosis. In this situation, diagnostic investigation definitely will be important. But if there are no clean-cut features for the SLE, then we are confused. Even it is inflammatory disease or not also, we are confused. In that time, only CBC, ESR and CRP. Okay? When you are clinically maybe 2 or 3 features of SLE there, so in the first instance, in the first line investigation will be CBC, ESR, CRP with anti-nuclear antibody. Okay. Sometime in our practice, an advanced clinician, rather to say confident clinician, will include anti-dsDNA also. Okay?
Okay.
That means because you are clinically confident for SLE. Now I'm going back and starting in a different way. You are thinking patient having the joint disease in the hands. You are confused that hand joint problem may be of SLE or even maybe of rheumatoid arthritis. Then what you will do? You will do CBCSS CRP plus ANA plus rheumatoid factor. Minimum. Understand?
Okay. Yes.
It is just like tossing a coin. Coin will be this side or that side. Okay? Tossing a coin. It depends upon you how you will plan. Not for each and every patient all the investigations.
Yes.
So if I am confused as a doctor, this is inflammatory disease at all or not, so our investigation will be CBCSS CRP. But if I think it could be SLE, then it will be ANA. But I cannot think of SLE or rheumatoid arthritis. It could be ANA and rheumatoid factor both. If I am confident clinically this is SLE, we will include anti-dsDNA. Okay. Again, if I am in favor of rheumatoid arthritis, I will not include anti-dsDNA. I will include anti-CCP. But again, I am confused about the rheumatoid arthritis and SLE. I will include both anti-CCP and anti-dsDNA. Okay?
Yeah.
But this patient not having the features of rheumatoid arthritis, not features of SLE also, it could be other connective tissue disease like scleroderma or other disease. I will show you a little later. Then I will advise for ENA panel. I hope a little bit clear to you now, all of you.
Yes. Yes, sir.
What are the fallacies of this test? Especially for the positive rheumatoid factor, if without clinical presentations, we shouldn't go for rheumatoid factor test. It will confuse us. In normal healthy people also, rheumatoid factor may be positive. Okay, this is the hard message I like to share with you. Second thing, the rheumatoid factor qualities. Qualities means significance of this thing. Rheumatoid factor may have prognostic informations, not only for diagnostic. Rather, as a single investigation, rheumatoid factor have very less powerful diagnostic test. Okay. Anti-CCP have very strong effect or influence in our diagnosis. High specificity, more than 95%. Sensitivity, 70%, but specificity. If you come into our biostatistics session, you will understand what is the meaning of a specificity and sensitivity. Today, better to avoid. And even it is said that sometime anti-CCP may indicate the presence of disease after 10 years. Today, patient doesn't have the typical rheumatoid arthritis. But if you find anti-CCP positive today, you can forecast this patient may have rheumatoid arthritis in future. So this is very powerful test. Now come to SLE related message, anti-nuclear antibody. Again the same. In the low titer, healthy people will have positive the anti-nuclear antibody. Now what is the message for you? Oh, sorry. Again, ENA profile, extractable nuclear antigens. Accordingly, you know the name of the diseases, the Sjogren syndrome, mixed connective tissue disease, polymyositis, dermatomyositis. It has some specific diagnostic antigens. That means we will identify the antibody. This is the example of that. So, in the investigation for the rheumatology, those we are dealing commonly the multisystemic disease, you will be agreed with me now that there is no single diagnostic test to diagnose the disease. True or false, doctor? If you understand my talk, you will respond now. True or false? That if the disease is positive, then this is the diagnosis, like diabetes. Any test available in the rheumatology? Dr. Rita, please.
Yes. Sorry.
Is there any test, single test? If the test is positive, I can say that this is that disease. Is there any disease in rheumatology or musculoskeletal system?
Anti-CCP.
No, 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 doctor. Anti-CCP give a powerful influence in the diagnosis. But in the rheumatologic, that is the rheumatoid disease, we need to rely upon diagnostic criteria. Clear now?
Okay.
Similarly, in the SLE also, no single test will diagnose SLE. We have to rely upon diagnostic criteria. Again, in the low back pain patient and ankylosing spondylitis, is there any diagnostic test? No. We need to rely upon clinical symptom, imaging, and other features. So all the rheumatologic diseases are as such. Possibly this is the bottom line of today's discussion. We need to rely upon
Features.
diagnostic features. We have to count the diagnostic features, 4 features, 6 features. Okay. So actually this is not the time to detail. I hope if anybody will be with us in our coming sessions in the rheumatology classes, we will discuss disease wise some other details, or those who attended before in our AKT before, you understand it. Okay. Just for your curiosity, what is the meaning of diffuse ANA? ANA pattern also indicate the disease. Homogeneous, diffuse, it indicates one disease. Speckled ANA, nuclear ANA, like that. You have heard in the book, just I am showing to you to satisfy your desire. Because I also was curious about this before. Extractable means 6 main antigen and listed there. Okay. So these are the tests to diagnose the rheumatologic disease, but again, it is not single test to diagnose. We need to rely upon the clinical features. So more about the lupus erythematosus systemic. Okay. And to follow that means the monitoring of the disease of SLE, the proper test is NTDS-DNA. NTDS-DNA, it is not only diagnostic helpful for the diagnosis, rather it will be helpful for the monitoring, that is disease course NTDS-DNA. Okay, you see sensitivity is less but specificity is too much. Sensitivity is only 70%. Okay. In the management part of musculoskeletal disease, our main plan is to relieve the pain by the medication, multiple medication, physical activities, including the physical treatment, other modalities of the physical treatment as well, hot, cold, rise. You understand the rise. There are 4 features, especially in the orthopedic patient. Rest, ice, compression, and elevation. In the traumatic patient, important. Stretching exercise, a stress reduction technique. These are the terminology used by the physiatrist. And the x-ray to evaluate further also, right? In the orthopedics, we see that we do the repeated x-ray for union, malunion, and other as well. Okay. And remember that x-ray will not identify periarticular disease. Okay, X-ray will not identify periarticular disease. One question to you. If we need to see by our eyes in the rheumatologic disease of periarticular tissue, what investigation will be useful? Quickly, please, can you tell me?
MRI.
Very good. Very right. MRI. Nowadays, sometime ultrasound can identify doctor. Nowadays in South Asian countries also expertise are doing this ultrasound of musculoskeletal system. It is also cheaper, available, and harm is less, right? There are some risk of MRI or especially the CT scan. So ultrasound can help. So topics is over now. If any query, not query, we are coming to, if you be with me few minutes, I hope you will enjoy with me now a patient, because our target to learn and understand the patient. Okay, requesting you be with me few minutes. One patient I'm showing to you. Dr. Mohsin, as before, I remember your voice is very nice and clear. Can you read it for us so that I can get some rest few seconds? Dr. Mohsin. Mohsin there or not? Any colleague can help me to read? No one. Okay, Dr.
Uh,
Atif, please.
a 64-year-old gentleman comes to see you for the result of his X-ray. He was seen by a colleague 2 weeks ago with hip pain and was referred for plain films of his right hip. The X-ray report states loss of joint space, osteophyte formation, subchondral sclerosis, and subchondral cyst formation. What is the underlying cause of his hip pain?
I think all of you, almost all of you know the diagnosis. Cause means the disease. What disease?
Osteoarthritis.
That means they are describing this X-ray, right? Almost all features here. Clear, Dr. Atif? Dr. Atif, be connected.
Yeah. Yes,
This
sir.
is,
Yes,
this
sir.
is this is the X-ray. So what is the diagnosis?
It's I think it's osteoarthritis.
Osteoarthritis. Actually, I have shown you those who are very new today. This is the way of learning your question bundles, doctor. We will guide our colleagues previously we have done to read the question in this way, not directly reading like newspaper. Thought you design your thought process. We will talk more about in the coming session another day. So these are the 4 core features of osteoarthritis. Very good. Thank you very much. And this is osteoarthritis other features. Don't forget these. Now the second case, who will feel better to read it? Again, Dr. Atif or other? May I request Dr. Atif again?
A 40-year-old woman attends with
45-year-old woman.
a 45-year-old woman attends with foot pain. She reports she has had pain affecting the underside of her right foot for the last 3 to 4 weeks. She denies any injury or trauma. The pain is worse when she wakes in the morning and takes her first few steps, and after she has been rested for a prolonged period and then gets up to walk. The pain locates to the posterior third of the plantar aspect of the foot. On examination, you are able to reproduce the pain with firm palpation, about 4 to 5 centimeters anterior to the heel. There are no other examination findings of note. Which of the following is the most appropriate image to perform at this stage?
I think all of you today, by after today's discussion, you know the diagnosis, right? Any confusion of you, anyone about the diagnosis? I hope almost 100% or 99% you understand the diagnosis. Now, what is the appropriate imaging will you do in this situation? Doctor, who will tell me the diagnosis? Anyone other than Dr. Atif? Anyone? Very nice description is there. What is the diagnosis?
Plantar fasciitis.
Okay. Could be other than plantar fasciitis. Why not calcaneal spar? Okay. It could be calcaneal spar also. Understand? But as mentioned there, reproduce the pain with a firm palpation about 4-5 centimeter anterior to the heel. There may be distal pain also. Anyway, whatever calcaneal spur or the plantar fasciitis, presentation is same. Okay. Do you need any imaging now? Options are there. So these are the key features already you understood. These are the options. What will be the best answer?
Plain X-ray.
Plain X-ray.
C.
Okay. C. C? C
D.
means
C. No imaging.
imaging, MRI. You are very rich doctor and your patients are also very rich.
No imaging, sir.
No
C.
imaging? Fantastic answer, doctor. Why you are thinking no imaging? We'll come to you to ask you again. Any other
Mainly
option?
Plain X-ray, sir.
Plain X-ray. Good.
You
Why not
see
ultrasound?
calcaneal spur.
To see the calcaneal spur. Okay. Any other options? Why not somebody ultrasound? Somebody will say bone scan. All answers are correct. But about the no imaging, very interesting. Who said no imaging? Please, can you respond? No imaging. I like to hear from you. Dr. HK,
mainly
abbreviated
it's
name.
a
Can you
mainly it's a
explain?
mainly it's a clinical diagnosis.
Usually we do diagnosis clinically and we need to confirm it by some other investigations also.
Yes, then I agree. X-ray to check for calcaneal spur.
Okay. But what is the aim of diagnosis? For the treatment is the aim, right? So we are now in the position of the family physician. What is our plan to make and good management? Doctor, you are disconnected. It will be better for me for a good discussion if you are connected. As you answered nicely, very different answer from there. I like to tell you now the philosophy or concept of family practice or preparation of the exam. First of all, let me say the answer. I think all of you understood. No imaging. The explanation is that for only the diagnosis, whenever we think of imaging and other, if I am confused, I already told before in the imaging, the investigation talk about the CBC, CRP, ANA, rheumatoid arthritis. The philosophy is same. If clinically the features are that much confident, actually we don't need to go for any imaging. Whatever it is spare, whatever it is the plantar fasciitis, if it's a unilateral, is a local problem. We need the treatment now, not the imaging. Okay, so this is the extraordinary thing we have to learn to be family physician, and this is explanation. Okay, ultrasound MRI can demonstrate. This is good. Should be used selectively, not for all patients. So Royal College actually advised that they don't go for imaging. Most patient with heel pain should be managed on the basis of clinical finding without imaging. What is the treatment? Physiotherapy, painkiller and others. For this reason, the going for the imaging will be worst stage, and patient definitely will get some unnecessary radiation also. A little hazard is there. So this is the concept that we like to discuss, and all of you doctor, those who are appearing newly for the AKT, message for you. Some of you possibly actually gone through the AKT exam, but newer. Our message is that this is the philosophy you have to understand. Whenever you are a specialist, without MRI or ultrasound or X-ray, you will not go through. But as a family physician, especially for the exam purpose, you need to be oriented for your exam. Okay, so this is one of the example that. So we will show by the mercy of Almighty in our next courses many other things that we need to think as family physician, not internal medicine specialist or rheumatologist. And this is main thing. It is the main thing. Just pediatric issues I will not discuss, doctor, as AKT exam you need to come across children with musculoskeletal pain of unknown cause. This is the slide. If you please make a snapshot. I thought that it will be highlighted to you. This is important, and possibly there is a question of acuity also. Growing pain in the young patient, child. What is the growing pain and how to deal it? Usually reassurance and analgesia. One thing. Second thing, the limping child differentials. Limping child. Okay, it is called the limping gait also. Even sometime there may be underlying appendicitis also. Patient may have the limping. Okay, and these are the whole limping issues. Limping issues means detail, you will get details in the book, Parthes disease, and definitely this will be discussed in the course, detail those who will be. And the management of sport injuries. A family physician can play a role in the sports medicine also, though there are some specialization. Again, the rise, you see rest, eyes, analgesia, compression, elevation, trauma related. So have some idea of sport related problems. So thank you very much. Thank you.
Thank you, sir. Thank you so much.
And ma salama to you, especially for my Arab colleagues today.
Thank you.
Thank you, sir.